I've got no financial interest to disclose here. So we thought when we were talking to me and Ajay were talking, we thought we will tailor this talk and give some insight of how the diabetes in general is managed in UK. Bear in mind that every state, every country has a different pathways which is dependent on the population, what the state-sponsored sort of services are. And I'm very mindful that it is not replicable or in India because of the resources and everything, but I will give you some insights how we manage, okay? So generally all the people who live in UK, they have a registered doctor, and as soon as a person is diagnosed with diabetes, there is a diabetic registers which goes into it. And this diabetic register feeds into the diabetic screening program, which is called as the NHS diabetic screening program, which gets updated every month, okay? So from there on, next please. Next slide, okay. So what happens from there, the national screening program, there are different screening programs in different regions of the UK. They send an invitee for that patient to come and have the diabetic screening program. Just to give you a synopsis of things, we have got about 60 million people living in UK, and the current data from 2016-17 Department of Health says there are about 3 million diabetics, so that about 5% of people are diabetic. As expectedly, 90% are type 2 diabetics, and 2.6 million in a year were offered diabetic screening to attend so that they can have their pictures taken, and there were 2.2 million people who actually attended. So it's a well sort of a program running very well, about 85 to 90% sort of an intake as well. So bear in mind that has an important bearing. So what happens when that patient goes to the screening program? Obviously they will have the vision, they will have the dilation, and then they get two field stereopsis pictures taken. One is a disc center, and one is the macular centers, okay? So from then, that it goes to the grader, who are primary grader. Bear in mind that they are not ophthalmologists. They are technicians who have been trained to grade the images. And I've just put in a slide highlighting how the English screening programs work. We grade into R0, R1, R2, and I've put an equivalent grades of the ETDRS as well. So basically R0 means there's no diabetic retinopathy. They get sent home. Means all these patients get home after the pictures, and they get an annual appointment that is automatically generated. R1 is your equivalent of mild to moderate. Again, they remain in the population. They get a 6 yearly appointment as well. R2, which is your moderate to very severe non-proliferative diabetic retinopathy, they get sent to the hospital eye services. So up till now, the patient is all in the primary care. It's not coming to the secondary care, which is the hospital. And bear in mind, everything is free. There's no costing involved to the patient also. Okay, so they get referred to be seen in the hospital, and we have a target that we need to see these patients within 6 weeks. Okay, and people who are diabetic, means a proliferative disease, they again hospital, and we have a target to see them within the 2 weeks appointment. Okay. Similarly, there is a maculopathy as well. With no maculopathy, they remain in the community, get seen every year. Then any maculopathy, they get referred to the hospital secondary eye care. And then this is the criteria of it. So a lot of referrals come to the hospital eye services because of the strict criteria. Okay, bear in mind, again, these are not ophthalmologists. They have to stick to these graders, have to stick to these criteria, and the hospital has a duty to take on these referrals. So we do generate a lot of false referrals from these because they may not be necessarily needing treating. So what has happened, this is what we are trying to replicate across the country in the UK. This is a flow chart from my sort of a Southampton hospital. So when these patients get referral, what we have tried to generate is an OCT virtual clinics. Okay, so trying to save the resources, manage the resources, because they don't necessarily need to see the ophthalmologist. So they get a OCT pictures they can. So if they identify that there is a definitive treating maculopathy or a macular edema as per the ETDRS, then only they get a hospital appointment to see the clinicians. Otherwise, a lot of these, they go back to the screening program for a 6-month screening. Okay. So this is how the treatment program works in the UK. Okay, so the retinopathies, so as I say, there are 2,3s, R3 proliferatives. Okay, they get generally the first line treatment is the lasers. And again, the target from the screening positive R3 to the first treatment is 4 weeks. So we got about another 2 weeks once this referral has come directly to the hospital. So they get lasers. The R2, once you've seen the clinic, you're happy that there's no new vessels. We work closely with the diabetologist. Generally, in my clinic, I've got an endocrinologist, a diabetologist sitting with me as well. So we try to make sure that, you know, it's not only the eyes, it's only one part of the disease. It affects the whole of the body. So to try and see if we can address their metabolic control as well, okay? But obviously, if you've done a full lasers, you do whatever you do, still active, then I tend to go early in these eyes. And if there is any obvious TRD, I tend to go early as well. Similarly, for maculopathy, we have a strict criteria. Generally, all these patients, when they come in, they have dilation OCTs, which is standard. So it's a non-paying kind of a thing. If the central retinal thickness is 400, you were talking about 450, ours is 400 criteria. If it's 400, they get anti-VEGF. Now, the anti-VEGF Lucentis or Eylea, that depends on different hospitals and their local protocols, but in generally, they all get an anti-VEGF. In my hospital, because we give a series of 5 Eylea, that's how the Eylea has been licensed in UK. And again, there's a logistic, you can't see them every month. So what we do is when they're coming for the third sort of a month for the injection, we just have a quick synapsis in the eye and also have a look at the other eye, and then we go, okay? So if there is a responsive, then they go into the PRN, as in when required. Then no response, they could get a steroid or an Ozurdex, generally is the first line, or we switch to Iluvien as well. Just a brief line, in the UK, we have started a video trial, which is a vitrectomy versus a standard care, where if patient is not responding after 3 anti-VEGF, the definition of the response is that there's still sort of a macular edema is more than 350. We are now recruiting as a primary vitrectomy plus the ERM and the ILM peel. Okay, even though the previous evidence, I think the logic behind that is that the early vitrectomy may be helping rather than waiting too late before these goes into it. Okay, if the central retinal thickness is less than 400, then depending on the diffuse or the focal, they get treatment. Anti-VEGF, the Avastin is not licensed to be used, just to, okay? So now we'll present some of the data from the Clarity study, which was the in-house UK study done by Shobha Shivaprasad. It was a clinical efficacies of intravitreal aflibercept versus pan-retinal photocoagulations for best-corrected visual acuities at 52. Mind it was a phase 2 non-inferiority study. Okay, this was published in Lancet 2017. Standard inclusion criterias. Okay, but just very briefly, that in these case of patients, they could have been treated previously with PRP because it's a phase 2 feasibility trial. Again, the inclusions are pretty standard. Okay, treatment, they were randomized 1:1 versus anti-VEGF versus lasers. The anti-VEGF was baseline 3 injections, 4, 8, 0, 4, and 8 weeks, and then they were from 12 weeks. If they needed, the disease was active, then they were given. I'll be very quick for the interest of the time. And then they had lasers. They were given lasers in generally 2 shots, and then from 12 weeks onwards, if needed, they were followed 8 weekly rather than the 4 weekly in the aflibercept. Okay, so can I? Yeah, okay. All right, okay. So this is just the vision criteria. So if you look, the people who were receiving the anti-VEGF, there was about 4 letter gains. Mind it, this is different. When the DRCRN network come, they were proving about 8 letters of improvement. I think we will have another discussion around that later on. And same, okay. So if you look at the complications, pretty standard, but I want to highlight again that people requiring vitrectomies and the new vitreous hemorrhage, though statistically not very significant, what was higher in the PRP group. Okay, so just a last slide. Okay, in the Clarity study, there was only 4.4 injections in 12 months' time, whereas in the DRCRN, there was 7 injections in the DRCRN. Okay, the letter gain was different between the 2 groups as well. But why are we seeing this difference? Probably the Eylea has a long, sort of a different mechanism of actions, has a binding affinities for different molecules, which is VEGF-A, V. I don't need to teach about it, but that's well recognized. And in the Clarity study, there was a mixture of high and low risk diabetic populations, but there was no DMO. And 50% of the people had already had some PRP before they were recruited. So that might explain that they needed less injections, but there was no macular edema, so the visual gain was slightly less as compared to your DRCRN as well. And in DRCRN network, there were high-risk populations, and about 1 in 5 or 20% people had DMO. So in summary, these two landmark trials have given us some insight, some new thoughts to think about how we can manage our PDR cases. But bear in mind, the DRCRN 5-year data has come out, which says that at 5 years, the lasers anti-VEGFs have similar visual acuity effects, but there is a definitive difference in the visual field. Bear in mind, a lot of these people are young people. They're still driving. So this is something gets ignored when we treat people here, okay? Data, but learning from the AMD, yes, there is a reduction in the number of injections as we go on, but there's also a decline in what the vision we gain. But remember, one last line, that anti-VEGF is not therapy, is not a quick fix for all the problems. Thank you.